I proceed. I will talk today about the artifacts and the technical factors and the anomalous innervation. These are variables which can affect routine nerve conduction studies and our routine work. I would like to begin by acknowledgement to all the clinical neurophysiology unit, my professors, and also the residents, our students, who always are of great help. I would like to thank them in the beginning of the lecture. It's very important to master the technical problems that you can see and take care of them. Well, it is as if you are sharpening your saw before beginning. It is not a waste of time to begin with meticulous technique before collecting the data. It's not a waste of time. And of course, very serious problems can result from a wrong interpretation to the artifacts and anomalous innervation. You can mislead the clinician, you can have wrong diagnosis. And also, it's always written that when in doubt, think technical consideration. When in doubt, think anomalous innervation. So it is very important to master this. It's not a boring lecture. It's an everyday practice lecture in every case. I want you to keep in mind first that you are recording electricity, and the electricity is everywhere. You can record electricity from the electric source powers here, or you can give the patient electricity. You are giving it stimuli, and the patient has several electric sources rather than the one that you collect. He can move, he can have EMG artifacts, so there are multiple inputs coming to you. This will be very handicapping if you are recording small amplitude signals like the fibs and the sensory nerve action potentials. They need meticulous information. They are very small, and you have signal to noise ratio, small ratio, high ratio. And of course, I would like you to know that this potential that you see, until you see it this way with this amplitude and with this duration, several factors affecting it. Affect the formation before it is even born, the number of the fibers affected, the temperature under which the conditions were recorded. Also that transport, as you can see here, thick fibers, thin fibers, long distance, short distance, tissues and fluids.
Dr. Eman,
yes?
Can you make the voice to the maximum? There is hum during the lecture
okay,
coming from the voice.
Okay, I will try another thing, just a minute. Is this better, or still you can see, you can hear?
I think this is better. So for the audience, if there is, for me it's okay. If any problem coming,
I think the hum ended. There was a hum and it ended now. I think.
Yeah, they are saying it's better. Please go ahead, Dr. Eman. Thank you very much.
Okay, thank you. Also, you can, the potential that you record, you pick up other things rather than just the thing that you want. So you also pick up different things. And of course, at last, this is the display. It differs how you demonstrate it on the screen. As you can see, they are these nice babies. You can display them in different ways. So this is the journey of the potential before you see it on the screen. I would like to begin first with the temperature. The temperature, as you can see here, is during the formation of it. The temperature affects the gates of the sodium channels and make them doesn't close or delay the closure of the sodium channels. So when you have more closure, more delayed closure, you have more sodium entering. And the duration of the depolarization phase of the action potential is prolonged. So the response will take longer time. So because it takes longer time, it will travel slower because in every node of round VA, it takes a longer time, so it delays the velocity. But the amplitude in this way, as you have more sodium and more time for the depolarization phase, there is, as if pseudo increment, all the potentials summate together, and you see a higher amplitude. So when we understand the physiology, we can understand what can you see in the routine nerve conduction studies. You can see the amplitude bigger. It is not bigger. You know that the compound muscle action potential reaches a maximum and we stop. It is not really bigger. It's more summated. And the latency is increased because the velocity decreased and the duration increases because the duration of every single action potential is prolonged. Okay, and the same happens in the EMG when you record single fiber action potentials summated. The duration increases because the duration of the depolarization phase of the action potential increases, and the phases also increase as the duration increases. If you see this without knowing the temperature, you can think this patient have a pathology. He may have peripheral neuropathy. The latencies are increased, the duration increases, the velocity decreases. The EMG is not normal. The only thing that really draws your attention is that amplitudes are very, very good. So take care, the temperature can mislead you in peripheral neuropathy cases and in carpal tunnel cases. This is a small quiz. I hope you can solve it before I say that the velocity, to make it easier here, everything increases except the velocity, okay? This is the only thing that decreases in the temperature. So if we can see this and compare the values here with here, you can see that which is the cooler. We said that the decrease the temperature makes everything increase except the velocity. So this is the cooler. The top trace is the cooler one. And you can see how it affects it from 46 amplitude to 36 amplitude. How to deal with this factor? Well, the ideal temperature is 32 to 34. There is a very, I don't know, I don't like this equation. It's equation to calculate the differences that you can see according to the temperature. To make it simple, it is 2 to 1. 2 milliseconds for every 1 degree. Reduction in the conduction velocity, you said it will be slower. And 0.2 for everyone. The latency will increase 0.2 for everyone. But it is not good to use this equation at all. Remember that we will warm the patient rather than lose this equation. A very important tip I learned from Dr. Eric in a webinar by Dr. N and the Egyptian Clinical Neurophysiology, and I will recommend it later in the videos, that when you warm up to the wrist. You don't warm only here, because sometimes you use orthodromic techniques and you record from the wrist. So when you warm the hand of the patient, remember to make it to the wrist. And the best way to heating and the best duration of heating, well, the best duration is around 20 to 30, right? And the best way, the written lamps, water immersion, or local packs. And this is an article that saw that it is simple work, very simple ideas work. You don't need to immerse the patient, no need to put lamps on the patient. Just putting packs on the patient can work as effective as both. And for a tip for us, practical tip, this is our dear resident, Nerine. I would like to thank her. In January, when you have a long checklist with several patients and you have cases of carpal tunnel syndrome or peripheral neuropathy, you know it is cold temperature, so you don't need to enter the patient and then ask them to warm their hands. So please do warm their hands up to the wrist before they come to you. It will save you huge time. The effect of age, I will not go into details because we are targeting from 10 to 60 years. From my practice, I see from 2 to 65 years, the values are very okay and they can do good. These are two references in case any one of you wants to, pediatrician works very much with the neonates and whatever. This is for the adults. per decade from 20 to 90 years, and this is from neonates till 14 years. You can check the values for every nerve in these papers. The segment you are examining is very important also, because when you go proximal, the nerves are thicker, so they conduct faster. You know that the more myelin, the more conduction. And as you go distal, they go taper, so it is slower. So you are expecting to see velocities which are faster proximal than distal. It is expected and nothing problem. Also, there is cause is a temporal dispersion phenomenon. It is not the scope of this lecture. As the potential travels along distance, it gets smaller due to phase cancellation and electric phenomena. You can check it. The height is also a factor. Well, we don't see this problem at all in Egypt. I think most of us of average height. I encountered this problem when I work for our neighbors in Africa. They are very tall, really, and you can. Once I just found this variable in a very tall person. These were the factors which are physiological or related to the patient. We can see non-physiological factors also, and they are more challenging and very time-consuming. The most number one and the most important is the noise. The noise, we said that the electricity is everywhere and we can pick it up from everywhere. So this everywhere comes to us, and this everywhere comes for us to and tries to enter the machine. What we are going to do? There is room level, what are going to do the room, at the electrode level and at the cables level. At the room level, the grounding is not the grounding for the machine is for an electric engineers. They usually come and ground it to a metal outside the building. But we can do unplug, not switch off only the machines, because even if they are in the electricity and not working, they act as antenna, and all the electricity passing from here, you can collect them. So unplug, not only switch off. And if you can use lights, not tube lights, these circular lights, they have lower electromagnetic field, and if you can't, you can just dim the light a bit when you are recording. At the electrode level and the cable level, not the room level, what we are going to do before we proceed, we have to understand the concept of differential amplification. We have two electrodes that we put, and we pick the difference between the two electrodes. The active electrode is supposed to be the target, and the reference electrode is the zero potential. We don't want to record anything from it, and we record the difference between these, and they enter and they amplify the difference. And when it amplifies the difference, we can see the signal. So this noise, if the signal, the noise enters at this one, the same as this one, so when we have the difference, calculate the difference before amplification, they will cancel each other. And you, as if you see nothing, you saw nothing. But if there is a difference between this one and this one, the difference will be amplified and it will be recorded on top of the potential. So this means that you need to, if you cannot erase these all electromagnetic waves, you need at least to equalize their input between the active and the reference. To equalize the input, it means that you have to check equal impedance. Impedance is the resistance to the current flow. You want equal impedance. Of course, this picture is a demonstration of unequal impedance. Of course, we don't do this at all. It is just a demonstration of how come if you do unequal inputs, you will have this noise. So you have to use the same cable types, the same amount of gel between them. You have to clean properly between them. You have so that they carry the same signal. At the cable level, these are the cables. This is also wrong. The cable also acts as an antenna and picks up and emits the electricity. So you need them all to record the same because before entering the differential application so that they cancel each other. So here, when you put them widespread, everyone is picking up the interference or the noise with different amplitudes. So this is completely wrong. You have to make them all together, and sometimes there are twisted cables to unify the amount of electricity rather than the desired signal which are passing through them. And of course, as they travel shorter distance, they carry less noise. So try to make the limb shorter and use shorter cables, the limb closer, and use shorter cables rather than very long cables, and make them close together. There is something wrong in this picture other than what I said, and I will return to it later. After all this, we can use something called the averaging. The averaging is this: you repeat the response several times over each other. And we know that the signal that we want is not random. And when you submit it, you get it better, more. But the noise is random. So when you average it or submit it, it cancels each other on repeated summation. But this doesn't mean that you have a poor technique and you submit, because when you submit on a very poor technique and very big stimulus, it also distorted. And the averaging is painful. So do not use it as for granted. You will know you average. It's painful, and it is not a substitute for the poor technique. It is limited for the plantar nerves, the choral nerve, the saphenous nerve, the nerves who have small amplitude. Well, the filters. The filters, I don't like the filters. You know, I think I always thought it is very difficult. So I like to put this deer in front instead of the potential, well, as if this is the potential we are going to see. And the filters are the window we are going to see through them this potential. The filters, low is high and high is low. You have to know the terminology, because when you see in the screen of the display high pass, you have to know what does it mean, high pass and low pass. They are the low frequency filter. This cutoff will not let you see the lower and will let you see the higher frequency. Here will be the low frequency filter. And it is called high pass because it passes higher filters, higher frequency waves. And here is the high frequency filter. It allows slower frequency waves and blocks higher frequency waves. So this is the window that you see finally. It is a way how you pick up the potential that you want to see. After we understood the filters, what is high and what is low, I would like to tell you what the filters do to the potential that you want. When the low frequency waves, like the delta waves, they have long duration. So when you increase the low frequency, allowing more slow waves to enter, you expect the duration to increase. And you see the potential with broad duration, long duration. Well, the high waves, when they cluster together, because they have narrow duration, they can submit easily, so they can cause higher amplitude when they are added more. Also, the lower waves cause higher amplitude. But to make it simple, because there are too many details in the filter's way, let us agree on that increasing the low frequency filter, allowing more waves, increase the duration, and increasing high frequency filter, allowing more high frequency waves, increases the amplitude. This is another quiz. I hope if I explained it simply, I expect that everyone can understand which have the higher filter. Is it the top trace with the higher filter or the bottom trace? Well, it is the top trace because it has a higher amplitude, and we agreed that the higher amplitude has higher filters. As I said, it is not that simple, only the filters, and I think it is just, we just check the filters and memorize them before we analyze the waves is much more simpler than understanding all the details of the filters. But who is interested, this is a very nice paper describing the filters in details. Well, the filters versus the sweep and sensitivity. We can see that the filters affect the amplitude and affect the duration. It is the same when you change the sweep, and when you change the sensitivity, you can see bigger or longer duration waves. But the filters is due to the pickup, how you picked up the band you took. And the sweep and sensitivity is how you displayed it. You already took the signal and how you are going to display it to others. This is the sensitivity, which means 5 millivolt means that every vertical square is with 5 millivolt. And here it is 5 microvolt, which means that every vertical square is 5 microvolt. Of course, when we change this, we expect the potential to change. How? This is the same potential. It is just how you display it. Here at A, the sensitivity is 1 millivolt. Every square 1. Here, D, it is 10 millivolt. So this is not a low amplitude potential. It is just that the display is different. It's very important because I see several problems when you try to see injury or detect a pathology. You can never use this baseline 5 millivolt per division. This is unacceptable. You have to change the game before documenting any absent response. Cannot begin like this ever. Let's talk about the sweep. The sweep is the horizontal, not the vertical. When every square horizontal represents more, we expect the response to be broader. And this is not just the morphology of what we see, it is what we calculate. When you see a broader response, the takeoff is different, which is the latency. You can measure wrong latency due to the display problem up to 0.5 millisecond, and we know in the carpal the comparative tests are 0.5 milliseconds, so we cannot afford to have an 0.5 millisecond due to improper latency calculation. Distances in the electrodiagnostic lab is very important. Let's see several distances problem that we have. Number one, the distance between what we record, the recording and the nerve itself. So this distance is increased in two conditions. We can see them daily. If there is edema, we several times see after breast cancer, we see lymphedema, and they ask us to, if the patient has problem, to see if she has brachial plexus problem or not. And she comes with the edema, and you expect that everything will be absent in this, because it is not due, it is really absent. It is absent because you have intervention between them. And in the obesity, you are expecting in such patient that you cannot record the phrenic nerve, you cannot record the lateral cutaneous nerve. So what are we going to do in obese or in edematous patient? There is a nice paper about the risks and hazards in the neurophysiology lab. And in lymphedema after breast cancer, you cannot put the needle. It's not 100% that you can. Sometimes it's very limited to the risk benefit. You are exposing the patient to very high risk cellulitis versus what? What are you going to prove? So in this case, it is not recommended to do anything. If the patient is obese, you can insert a needle rather than the surface electrode to try to pick up the potential you want. Another distance between them is where you put the electrode, the recording electrode, in relation to the real place of what you want to pick. Here in the mixed median sensory, we are stimulating the palm and we are recording from the nerve itself. Every time you put the pickup electrodes away from what you see due to poor placement, or they are variation in the people, it is not exactly in its place, you can expect huge amplitude problems. And we can say from 38 to 12, it is just 1 centimeter, not in the ideal place. So before you document any low amplitude response, please try to move your pickup 1 centimeter lateral in every direction. But when you move your electrode, pickup electrode, please wipe correctly the old place, because if you don't wipe the gel from the old place, you did not eliminate it, because the gel or the paste will be under the electrode and adjacent to it, so you are already picking. So clean up well before reapplying the electrodes. We have the distance between the active and the reference. Well, the webinar I told you about, which Dr. Stalberg, is very interesting in this problem. Dr. Stalberg put the active on one limb and put the reference on the other limb. It was very nice, and I strongly recommend that you see it. He wanted to see, he said that he was retired and he wanted to know after retirement, so he wanted to check every basics that he want. So he tried several things. It was a very nice lecture. Well, he recommended several tips I will tell you during this lecture later, but to know for routine, the distance between the active and the reference should be kept 3 to 4 centimeters. Why? You want not to, here the distance is very narrow to each other. So the depolarization occurs under both the same time. So there will be not enough difference to amplify. So 3 to 4 centimeters is the acceptable distance between them, not to overlap with each other. Another distances, which is very important in our electrodiagnostic studies, is how you measure the distance before entering it to the machine. There is special nerves that need special distances. Well, you can see here the plantar nerves are around the medial malleolus, so do not just take the distance like this. When you take incorrect distance, you will calculate incorrect velocity. The same here with the ulnar nerve. The ulnar nerve, the true length of the ulnar nerve should be taken with the elbow flexed 90 to 130 degrees. Otherwise, it's not the real length of the nerve. This is another quiz for a distance problem that we can see. Here, this is the stimulator, and this is the active. Of course, what you think is the problem in these? Well, this one is recording from the anode to the active, and this one is recording from the cathode to the active. This can make a latency difference up to 0.4 milliseconds, which is very important in us. So when you take a distance, please take it from the anode, the cathode, not from the anode. Some problems are related to the stimulation. Let's show the stimulation technique, not the distances. Let's see how the stimulation can affect the response. The stimulus artifact. It's one of the huge, major problems that we see in the electrodiagnostic studies. That you pick what you give. You give him stimulus, you give the patient stimulus, and you pick it. What is the problem when I pick this stimulus? It's not just I want a good morphology for the response, I want accurate reading. This will affect this amplitude, is not like this amplitude, and is not like this amplitude, and the latency is not the same. So eliminating stimulus artifact reduces the error in the latency and the amplitude calculation. How can we reduce the stimulus artifact? Well, let's think that the desired potential is a lovely song, and the stimulus artifact is the noise which overcomes this lovely song. When you hear a noise with a song, what do? You try to lower the noise. How come I try to lower the stimulus? I improve the technique. I clean very well. I use gel. I secure the place of it. So I place it in the exact point. So I have to use lower intensity. But if you didn't clean and you didn't use gel and you put it off point, you will have to use stronger intensity. So proper technique can help you lower the intensity. And if you hear a noise with a lovely song, you want it to be away from you. So increase the distance between the stimulator and between the electrodes. I can see the beginners, our dear juniors, putting the stimulator very, very near to the electrodes. I don't know why. It will get the same results when you put it just 1 or 2 centimeters above. And of course, when you hear a song with a noise, you want an insulator between you and this noise. The insulator is the ground. When you put ground between the recording electrodes and the stimulator, this is the stimulator, I will let you see, the stimulator and the recording electrodes, there is a ground in between always as an insulator between you and what you don't want to pick. This is the ground. As you can see, it is always here. She's putting the stimulator near the ground. You can take it a bit higher. It will reduce the artifact. Also, here there is another problem I told you before, that you are putting the stimulator cable. This is not the reference nor the active. This is the stimulator cable. You are putting it among the recording cables. And we previously agreed that these cables pick interference and pick the potentials that are around them. And so we don't want to put the stimulator cable near them, not to pick the stimulus artifact. And another very, very effective trick is to rotate the anode. You have a cathode and anode. This is the cathode and this is the anode. When you change the anode while keeping the cathode in place, we don't want to interfere with the stimulation point. We just want to change the field. So we want to make the anode just a bit to the right and just a bit to the left. This helps greatly to reduce the stimulus artifact. And there is a recommended video I will put in the last slides that I recommend you to see. It's just how the dipoles change. And Dr. Eric also said that rotating the anode affects the amplitude, and it was a nice thing. So don't rotate it too much, otherwise you will have smaller amplitude. For the stimulus, we are now talking about the stimulation and how it affects the technical part. For the stimulation, the intensity also is a parameter. Not also this, we want to ensure that all axons are depolarized, because as you can see here, you can interpret this as a pathologically low amplitude response, while actually you are not giving the enough stimulus intensity. So you slowly increase the intensity until you find that the amplitude is not increasing. You would then increase another extra 25%. If you reached 20, you can reach another 5, increase another 5, 25 milliampere to ensure that all the fibers are stimulated. Well, you can say, I can just put the stimulator on the maximum intensity and just this will make sure that all the fibers are okay. Well, no, because when you have too high intensity, you will have co-stimulation of you will stimulate other nerves. When you do this at the ulnar, you can stimulate the median. So it is not just you put the high intensity and so. And also, we know that we pick near potentials that the desired one that I want, and we pick far potentials that I don't want. So increasing the intensity will produce more volume conduction. Far field potentials will cause more distorted response. This is what I mean, the co-stimulation. The co-stimulation is very important, especially in injuries where the nerve is absent. And you put on the median, it is absent, but using very high intensity stimulates the ulnar. And you record a potential from the field. Several ways to reduce co-stimulation, as we said, to reduce the stimulus intensity, but very important to detect it. Detect that you are stimulating the wrong nerve. Well, very common, you see thumb abduction. When you are stimulating the median and seeing thumb abduction, you are not stimulating the median. The abductor is the ulnar innervated muscle. So watching the twitches is important. Also, watching the morphology of the potential. You can see that slightly to the right and slightly to the left. If you are stimulating median, you will record a shape. And when you stimulate the ulnar, you will record another shape from the same muscle. So the shape will change also. These are the most important tips to prevent co-stimulation. The electrode location, where to put the active and where to put the reference, affects greatly what you see. Well, the electrode location, we know for the muscle tendon montage, it is put on the muscle belly. We are talking about the reference electrode now, and we will talk about the active electrode later. We put the reference on the tendon in most of the recordings, but now it is strongly recommended that in the hands and in the feet, you don't put on the here, you put on the distal joint. When you record this, the abductor digiti minimi, you put on the distal. And when you record from the abductor pollicis, you put on the distal. Why? Here in the hand and in the feet, the same for the tibial nerve. In the hand and in the foot, there are so many intrinsic muscles. The intrinsic muscles produce a positive far field potential. And the tendon produces a small positive potential, very small. Here, the tendon potential over the intrinsic muscles, which are the far field, make submit together and affect it more. So it is recommended in the hand, in the feet, and to put on the distal interpharyngeal joint. The tibialis anterior also don't put on the tendon, put on the patella, it will respond better response. And the biceps, don't put on the tendon, put on the acromion, it will put a better response. And this is the recommended watching video. I will tell you, I put them in a last slide together. Well, where to put the active, not the reference. We are now talking about the active electrode and where to put it. If we put the active electrode not exactly on the motor point that we want, the potential that you are seeing represents the approach of the depolarization, then the depolarization process itself. The approach is an initial positive deflection. So you see an initial positive deflection. If you put it exactly under the site where the depolarization begins, you get a biphasic potential, essentially negative in the up. This is how you know that you are in the correct point. And of course, if you are not in the correct, it's not only that you have a positive beginning, the amplitude will not be good because not all the fibers you are not picking from all the fibers. So you expect a lower amplitude response. This is a quiz. I hope if I really explained it good, that you will be able to know it, which potential is off point. Well, this one, because it has initial positive, and you can see it is number of squares. It's not written how much is the amplitude, but you can calculate the number of squares, so this is smaller. I think for the technical part, this is okay. This is not everything I wanted to tell you, but I didn't want to go into so many details. I just want you to understand the concept rather than memorize every single detail. I hope I did good in the first part and you understood what I said. If you want a break before the anomalous innervation, is okay. What do you think, Dr. N and Dr. Aya? Or I can proceed another 10 minutes. What do you think?
Open the mic.
We are enjoying the lecture, so it's up to you.
No, I can proceed. Okay, thank you.
We are enjoying what you're saying. This is it's not an easy task, by the way. This is one of the very, very, very difficult lectures to make it easy for others. So take your time.
Thank you, Dr. A. Well, I guess I will proceed, not because if anyone have another dates after my lecture. The anomalous innervation also is very nice topic. Well, I didn't see it frequent. I don't know if I missed it or if I didn't encounter it. I hope I didn't encounter it frequently. I only saw it 3 times in my life, but I hope this. I tried to explain it with another perspective so that we can pick it up easier. Well, we don't know before entering the patient if he has anomalous innervation or not. And of course, while we are working, we are not encountered all the time that he is anomalous. We are expecting that he is okay most of the time. So when to do or to suspect anomalous innervation, when you see unexpected amplitudes, when you see block, when you see absent responses. Before documenting block or absent responses, you have to screen your mind. Is there any anomalous innervation here? So let's see the first, of course, because it is amplitudes, so make sure that you are not overstimulating and co-stimulation, I think, or you are not under-stimulating everything before doubting anomalous innervation. I will begin with the Martin-Gruber anastomosis. Martin-Gruber anastomosis is that motor fibers go from the median nerve to the ulnar nerve in the forearm. These fibers, where are they going? 3 possibilities. They are either going to the abductor digiti minimi, or going to the first dorsal interosseous, or going to the adductor or deep head of flexor, which are ulnar innervated muscle. but now they are taking from the median. So we have three possibilities, either this or this or this. I would like to see what you're going to see and how you're going to check for Martin Gruber. What you are going to see, we have three ulnar scenarios. When stimulating routine ulnar nerve, recording from FDI or ADM routine, what are you going to see to suspect Martin Gruber? Conduction block, below the elbow or above the elbow. When you see conduction block, below the elbow or above the elbow from ADM or FDI, in routine ulnar, you suspect Martin Gruber. The median, when you see as if there is block in the wrist, as if the wrist potential is blocked, is smaller, then you suspect Martin Gruber. What to do when I suspect Martin Gruber? I want to find Martin Gruber. What? Reverse. I stimulate the media, recording the ulnar muscles. And I stimulate the ulnar, recording the median muscles. This is the basic of what we are going to see in details later. Okay? When you do routine ulnar, you can see block at or above elbow. Routine median, you can see block at the wrist. Then you reverse switch the stimulation side. What are you going to see in every scenario? In the first scenario, let's move part by part. We are routine ulnar. We are going to stimulate the ulnar. Wrist is a large amplitude, normal potential. All the fibers are stimulated here in routine ulnar side. When I get here, some fibers are missing. So the amplitude here is lower than expected at the below elbow. What I'm going to do, I'm going to switch. I'm going to stimulate the median. When I stimulate the median here, I will get I will get no response at the wrist. This is median wrist because the fibers are not in my way. When I stimulate here, I get a response. So this is Martin Gruber anastomosis. The response here is the difference between these two. This is the first scenario. The second scenario is when you record from the first dorsal interosseous, not from the ADM. It is the same because it's the same basic spot. The wrist is okay. That's bit by bit. This is the ulnar nerve. When you stimulate the ulnar nerve, amplitude is great. When you stimulate the ulnar nerve here, it is smaller. The fibers here don't cross. But when I stimulate the median here, I get one extra potential than the previous one, this one. Why? Because there are several median innervated muscles here beside the one that I am picking from. So I can stimulate them. And when I stimulate the median here, I find the difference between these two. So it is the same as case one, but I have a one extra potential. The third scenario is the same as one or two when we record with the ulnar from the FDI or the ADM, but it will shift extra level. What does it mean, an extra level? These fibers are not here. They can get at a higher level. So when these fibers are at a higher level, when you stimulate, you find these two potentials are the same because the fibers are above them. And you find the problem when you get above elbow or at a higher level. So this is okay, and the block is here. And the median is as case number one. Let's imagine here that we have carpal tunnel on top of this. What we are going to do, sorry, let's make the carpal tunnel the last thing. The three scenarios where the ulnar scenarios when we do the ulnar conduction routine studies. Let's see what we see in median scenario. That we have stimulating here, this is the median nerve, as if block in the wrist. Why? Because when you stimulate the median nerve here, the fibers are missing. But when you stimulate it here, you find a higher response. When you stimulate the ulnar, you will find the difference between the two as exactly in the same scenarios. The problem here is when you have carpal tunnel. In carpal tunnel, you will have fibers under, these are fibers under the carpal tunnel, and these fibers are over the carpal tunnel. So you expect that these fibers are much faster than these fibers. So stimulating the wrist, you will have no problem. But when you stimulate the elbow, you have two pathways. Pathway that is slowed and a pathway which is very fast. So sometimes it even reaches before the other one. And as we can see here, that the potential here reached before 8.2 the millisecond, before the distal one, because it is entrapped. And of course here the velocity calculation will be very incorrect because it is not real path of the fibers. It's not always the same. Sometimes you see just a positive dip. This is the positive dip first before. Why is this positive? Because the fibers which is not passing through the carpal tunnel reaches faster and innervates all the ulnar muscles. They are far field muscles. So you get a positive potential before the one. It's a far field from the ulnar innervated muscle. So sometimes you see just a positive dip. Sometimes it arrives later, and you have a very fast conduction velocity, but it's not calculated properly. This one has a way that's blocked, and this one has a way that is very fast. Now for the accessory peroneal nerve. Accessory peroneal nerve, we agreed that we will have amplitude block. So the accessory peroneal, it gives the extensor digitorum brevis rather than the deep peroneal. So when we stimulate, here is a trace by our colleague, Dr. Alia Tawfiq. She, I would like to thank her so much. She found the accessory peroneal nerve, and she hanged this trace in the unit so that the juniors can always see them. As you can see, this is the ankle. The amplitude is small because here you are missing the other fibers. You just stimulate this. So the amplitude is small. When you go at the head of the fibula, the amplitude is much bigger. So you suspect that there is something here, a block, when we agreed that before suspecting block, exclude anomalous innervation. And here, when she had the lateral malleolus stimulated, this is the difference between both. These are not the only innervations, but this is the most common innervations that we see. There is ulnar to median anastomosis in the hand. There is ulnar to median in the forearm, and there is the sensory, superficial, radian, and ulnar. The last thing that I would like to end this lecture with is this. I was attending a live session from Dr. Devon Rubin, the editor in the Clinical Neurophysiology, Journal of Clinical Neurophysiology, associate editor, and he was performing unusual nerve conductions like the saphenous, the phrenic, and whatever. It was 90 minutes talk. It is interesting to see how others work, you know. So it is routine. When Dr. Devon Rubin stimulated the dorsal ulnar, he was trying to demonstrate to the patient, to the people, the dorsal ulnar, He didn't get it at once from the first time. And as if he was programmed, he just said, well, there is an anomalous innervation. It can be the superficial radial. So he twisted, he took the stimulator to the superficial radial, and he didn't find anything from the superficial radial. So he returned back to the dorsal ulnar, and he improved all the technique. He cleaned and averaged and increased the stimulus duration, and he found the response. So he did everything which the lecture is about. So it is very important to master these things, and I am very grateful. I hope I didn't make it long for you. I enjoyed being with you, and thanks Dr. Aya and Dr. Ann and everyone.